This conference will now be recorded.
Good morning, everyone. Today, the topic is hypoglycemia. Uh, hypoglycemia is a condition which you will see repeatedly in the casualty. So, if a patient presents with unconsciousness like or seizures, you have to first think about hypoglycemia. What is hypoglycemia? It is the decrease in the glucose concentration in the blood. So, since it is why hypoglycemia is so important is that it is very correctable. It is a very reversible disease condition. So the symptoms and manifestation will immediately improve if you correct the glucose levels. Uh, Whereas it causes the decrease in the glucose levels causes very morbid disorders like seizures and coma, and but these are acutely correctable, like the just with the IV glucose you can immediately correct it. So it is important to recognize the symptoms of hypoglycemia, and you should always keep it in the foremost of your mind when a patient presents in the casualty in the emergency department. uh, Whether the whatever the symptoms, whatever the complaint, whatever it is, first we have to check the glucose levels of the patient to see if the patient is in hypoglycemia, sometimes hyperglycemia. So it is a very important condition, not only in the emergency, even outside. When you see a patient fainting or suddenly going into unconsciousness, you have to first keep it in the mind. So coming to the topic, hypoglycemia is a clinical syndrome with diverse causes in which low plasma glucose concentration leads to symptoms and signs. And there is resolution of them when plasma glucose concentration is raised. So that is hypoglycemia. First, there should be a presence of low glucose levels, and they should cause the signs and symptoms. And there should be resolution of them when glucose concentration is raised. So hypoglycemia consists of three components. So what the normal plasma glucose levels are maintained at 70 to 110 milligrams of deciliters in the fasting state. So this is a very important number. The number 70 should be in your mind. So anything below 70 is considered as hypoglycemia. Uh, so we have discussed in the definition 3 points, right? Those 3 points are present in the Whipple's triad. What is Whipple's triad? This is the triad which we use to diagnose hypoglycemia. It is just it is very like it's common sense, but these three components should be present to name it as hypoglycemia. So diagnosis of hypoglycemia is not based on an absolute level. So just because the patient has a uh, like 40 50, that doesn't mean the patient is having hypoglycemia, or sorry, not 40 50, some 80 90. If the patient is having symptoms, uh, the symptoms should be present, which should be sweating, palpitations. We'll discuss the symptoms of hypoglycemia later. So first, the symptoms should be present. And when you suspect that these symptoms are because of hypoglycemia, when you check the glucose levels, they should be uh, we have to diagnose it with the plasma glucose levels. But the normally in emergency departments, we take the capillary blood for measuring. So that is not consistent. That's not the diagnostic for hyperglycemia, for measuring glucose levels. You have to take venous samples. The venous sample is the correct method to measure the glucose. So first, the symptoms should be present, and when you measure the plasma glucose levels, they should be less than 70. And the third point is there should be relief of symptoms after the plasma glucose level is raised. So these three components should be present to name it as hypoglycemia. And that is the Whipple's triad. Whipple's triad is a very important like 2 marks question or a MCQ bit. So you have to keep it in mind, Whipple's triad. So, what's the response of the body to hypoglycemia? So, what does the body do when there is decreased glucose levels? So, first we will see the normal, how the normal glucose levels are maintained. First, there is endogenous glucose production. So, we take the food and that converts into, there will be digestion, which through which glucose is produced, and it circulates in the body. So that is one. Second is hepatic glycogenolysis. The glycogen present in the liver, glycogen stores are present in the liver, where all the glucose is condensed into glycogen, and it is stored in the liver. So when that glycogen again, um, when it is again broken down, it is converted into glucose. So that is another way for producing glucose. And there is hepatic gluconeogenesis. What is gluconeogenesis? When the any energy store like fat, amino acids, etc., when they are produced, when they are converted into glucose, then we call it as gluconeogenesis, right? So that and normally the gluconeogenesis is not commonly present. So when does the gluconeogenesis happens? It happens in the renal system and liver, and it is stimulated by low insulin levels. So when there is a chance of the body to go into hypoglycemia, then gluconeogenesis happens. Or when there is present of anti-insulin hormones like glycogen, when there is excessive glycogen, then we see gluconeogenesis. Or there is a supply of precursors from muscle and adipose tissue. So when there is a large amount of amino acids, lactose, uh, fat, free fatty acids from the muscle and adipose tissue, then they are converted into glucose. So what's the physiological response? So what happens first when the glucose levels decrease? So when the body detects that the glucose levels are decreasing, like it's at the level of 80 to 50, like in here. So this is the glycemic threshold. What glycemic threshold is the at the values at which there is a response to the uh, decreased glucose levels. So that threshold is 80 to 85 for the action of decreased insulin production. So what does insulin do? Insulin decreases the amount of glucose in the blood. So to as the body is slowly going into hypoglycemia, insulin action is decreased. Okay. So this is the first defense against hyperglycemia. Before the body goes into hypoglycemia, the body reacts by decreasing the production of insulin, and it stops it at 80 to 85, and it causes increased hunger signals. So it gives signals to the body that I'm getting hungry, so please feed me. So that's when we get first hungry. Then the second, after the, so we ignore that. Even when we get hungry, we will not take some food, and the body can go for some time, but it will not be able to maintain for much time. So after that, the glucose levels slowly fall to 65 to 70. So this is the glycemic threshold for glucagon. So what does glucagon do? It causes the increased glucose production. So the glucose production is increased by the glucagon. As we have seen here, when there is a presence of anti-insulin hormone like glucagon, it increases the uh, glucose levels. So at the 65 to 70 levels, the glucagon levels are increased. Then this is the second defense against hypoglycemia. So these all are primary glucose regulatory factors. One is regulatory and another is counter-regulatory. Okay. Um, After that, after this rise of glucagon, the glucose will raise, and simultaneously, when the glucagon is raised, the body also produces epinephrine. So this is the third defense against hyperglycemia. And what this epinephrine do is it stimulates the sympathetic nervous system. So epinephrine stimulates the sympathetic nervous system, which in turn causes symptoms like sweating, palpitations, tremors, diaphoresis, etc. So the symptoms of hypoglycemia are produced by increased epinephrine. So this is the critical hormone, and suppose if there is any glucagon deficiency in the body, suppose Epinephrine, the increased epinephrine is the one which causes the symptoms of hyperglycemia to be present. Okay. And if we go, if there is hyperglycemia, the glucagon can maintain, if it can maintain at 60 to 65 to 70, it is maintaining for some time. And if it goes into prolonged periods, then the next one is the increased cortisol and growth hormone. So this one also causes increased glucose in the body, but it acts in the late stage. Okay. So when there is a chronic hypoglycemia, when there is a chronic deficiency, then we have increased cortisol. So this increased cortisol causes it is also a state of sympathetic stimulation in the body, and prolonged hypoglycemia causes like Cushing-like syndromes because of the increased cortisol. Like you will have a fat deposition, adipose tissue deposition in the center of the body, like in the stomach area and like in the visceral area. There will be bloating, etc. So, and it also predisposes to diabetes. Okay, so increased cortisol is prolonged cortisol increase is not good for the health. Next, we have symptoms of uh, like acute symptoms of hyperglycemia at 50 to 55, and if we go below 50, then the behavioral response is decreased, and there is decreased cognition, which leads to coma. So what does the decreased insulin do? So we have talked it as first defense. So decreased insulin causes increased glycogenolysis and gluconeogenesis. So we already know that glycogenolysis and gluconeogenesis increases the glucose levels, and it also induces proteolysis and lipolysis. That means it breaks down the proteins and lipids, and it also reduces glucose utilization. So the amount taken by the body, the amount of the insulin used up, the glucose used up by the body will be decreased. So decreased insulin causes these effects. The second defense is increased glucagon. So what does glucagon do? Thus it just increases glycogenolysis. So it just increases the breakdown of glycogen to glucose in the liver. Increased epinephrine, so it inhibits insulin secretion. So it counteracts the insulin, and it also stimulates glycogenesis and gluconeogenesis, and it also increases the gluconeogenic substrates like the lactose, pyruvate, free fatty acids, amino acids. The substrates which are available for the gluconeogenesis will be increased by the epinephrine. Okay. Um, so it becomes very critical when glucagon is deficient, because it will be the only mechanism through which the glucose levels will be maintained if glucagon is deficient. As we have discussed, cortisol and growth hormone, it acts only in prolonged hypoglycemia, that means greater than 4 hours. So what are the clinical manifestations when a patient presents with these symptoms and signs in the OPD or emergency? First we have to think of hypoglycemia, because as this is the most so the symptoms are, we can divide it into neuroglycopenic and neurogenic. So neuroglycopenic are behavioral changes, confusion, fatigue, seizures, and death. So confusion is also a major symptom of hypoglycemia. Just think about how you feel when you are very hungry, like so hungry that it goes beyond, like when you sometimes have prolonged, like when you don't have food for 5 6 hours, what are the changes you have? You become irritable, sometimes you'll have sweating, there will be blurring of vision. So when so that's the, those are the hypoglycemic symptoms. We experience those symptoms in very little amounts when we go hungry for long periods. So just keep them in mind. Next symptoms are neurogenic. In the neurogenic, we have autonomic. So what are the autonomic systems which are activated? The autonomic systems are adrenergic and cholinergic. In adrenergic, we have palpitations, tremor, and anxiety. We also have a feeling of doom when we go when there is the hyperglycemia. Uh, s- so anxiety is also a feature. Whereas in cholinergic, when the cholinergic system is activated, we have sweating, hunger, even paresthesias. That means paresthesia means tingling and numbness sensations over the body. Whereas what are the signs? These are not that important, but these are the things we observe in a case of hyperglycemia. Those are diaphosis, that is extreme sweating, pallor. This is especially seen in prolonged hypoglycemia, increased BP and heart rate, obviously, and there can be transient focal neurological deficit. So, if we have a case of TIA or you think that it is a stroke, you have to first exclude hypoglycemia, because hypoglycemia is a very important cause of, it is a stroke mimicker. So when we think of stroke mimicker, we must also think of hypoglycemia. So this is the thing we have talked until now. So it in a flow chart. So first there will be decreased glucose. When there is decreased glucose, the pancreas will be stimulated. So the pancreas will it will decrease the insulin and increase glucagon. So both act on the liver. Okay, for gluconeogenesis and glycogenolysis, and kidney. Here gluconeogenesis happens. So these two causes increased glucose production. Okay, with increased glucose production, arterial glucose will be present. So this is the end result. And with the decreased arterial glucose, there will be also stimulation of brain. Why? Because it will stimulate the pituitary and there will be increased sympathoadrenal outflow. So when there is increased outflow, sympathetic outflow, it will stimulate the adrenal medulla. Okay, and as it is the site of production of epinephrine. So increased epinephrine will be present. As epinephrine also causes gluconeogenesis and glycogenolysis, it also stimulates the liver and kidney and causes increased glucose production. And there will be sympathetic postganglion neurons stimulation because of the sympathetic outflow. And as we have discussed in the symptoms, there will be adrenergic outflow and cholinergic outflow. Both causes symptoms, which leads to ingestion. Okay. The the liver and kidney also, the epinephrine mainly. Epinephrine, it causes the increased availability of gluconeogenic precursors like lactate, amino acid, glycerols. Lactate is present in the muscle. Yeah, like when we do any work, the lactate gets accumulated in the muscle, right? So it will be available for these conditions. So these substrates will be increasingly available. And and in the brain there is also stimulation of pituitary because it causes the increased growth hormone, and also ACTH is secreted in the pituitary, right? It stimulates adrenal cortex. So in the adrenal medulla we have increased epinephrine, whereas in the cortex we have increased cortisol. So these also act in the prevention of hypoglycemia. So this is the flow chart for all the mechanism in the glucose production. So, okay. First, we have to divide the hypoglycemia into two categories. One, in the hypoglycemia which we see in diabetics is an altogether different from which we see from non-diabetics. So the both are the separate, like they have both have separate mechanisms. I mean this is all same in everything, but in the diabetics there will be destruction of the pancreas. So this decreased insulin and increased glucagon, it is gone in the diabetics, or else decreased. These responses are decreased in the diabetics. So it is altogether a different game of hyperglycemia and diabetics. So we have to not treat it. We have to approach it in a different manner. It will be, so it causes recurrent morbidity in most people with type 1 diabetics and advanced type 2 diabetics. So what's the difference between type 1 and type 2? In the type 1 diabetics, there is a complete loss of islet cells in the pancreas. So they almost have negligible amount of insulin present in them. So all the insulin that is present is provided, we should provide it from outside. So that's whereas in type 2 diabetics, there is ongoing destruction of the pancreas. But in the initial stages, the pancreas secretes enough insulin to get over. Like we can manage it with oral drugs, it will be fine. But in advanced, once the all the islet cells are destroyed, it becomes equal to type 1 diabetics. So when a patient when we start using a huge amount of insulin from outside, like little amounts is fine, we are just giving insulin to give the pancreas a little bit of rest. So that's what we do in type 2 diabetes. But when the diabetes becomes so advanced that we have to substitute a large amount of insulin from outside, then we can take it as advanced type 2 diabetes. Okay, and it becomes equal to type 1 diabetes. Okay, the so type 1 diabetes suffer an average of 2 episodes of systematic hypoglycemia per week and at least 1 episode severe disabling hypoglycemia per year. So it is a very important morbidity and mortality even in diabetics, especially type 1. It is less frequent in type 2 diabetics, but common in patients using insulin sulfonylureas and glinides. So we have discussed, right, over time, frequency of hypoglycemia in type 2 approaches that of type 1 as they reach the insulin deficient spectrum of the disease. So we have a spectrum in the insulin deficiency even. First, there will be enough production. There will be just in the type 2 diabetes, what is the major pathophysiology? So the first is there will be insulin resistance in the cells. Okay, so the cells become the body cells that take up the glucose become they do not respond to insulin. So there will be no response to the insulin. So a huge amount of insulin is required. So what does insulin do? It makes the glucose go into the cell. Okay, where the glucose is utilized by the cell. So but the cells are not large amounts of insulin for the glucose to be taken up by the cells. So when there is a more work on the insulin, there will be more stress and pressure, and eventually it starts giving out. It will not be able to maintain the the needs of the body. Like the increased insulin production takes a tolls on the pancreas, and startly one by one the cells go into apoptosis. Okay, so like that the cells go away and the amount of insulin produced by the pancreas also decreases. Okay, the functional part of the pancreas starts decreasing, and then that's the time when we start supplying it from the outside. I mean the amount of insulin we give becomes huge. Okay, we supply from outside. Okay, this is the basic pathology of diabetes, like very very basic. And lastly, the whole pancreas will be destroyed, and the patient becomes completely insulin dependent. So in the counter-regulatory response in hypoglycemia for diabetes and for non-diabetics, we have the previous slides we have seen is that for non-diabetics. So how it will be in diabetics. So in diabetics, first non-diabetics, we see decreased glucose, and there will be decreased insulin and increased glucagon and increased epinephrine. Whereas in type 1 diabetics, where there has been no where there is no insulin or glucagon production, there is no, when the glucose decreases, there is no decrease in insulin, where there is no increase in insulin, because there is nothing there are no pancreatic islet cells to produce them. There is just an epinephrine. There is an increase in epinephrine, that's it. Whereas in type 2 diabetes, early stages, so we have seen the spectrum, right? Early and late. In the early stages, it will be similar to that of non-diabetic. So insulin decreases, glucagon increases, and epinephrine increases. Whereas in the late stage, that is the absolute endogenous insulin deficiency, where the type 2 diabetes becomes insulin dependent. Same as in type 1 diabetics, there will be decreased insulin, there is no insulin production, decreased, and there is no increased glucagon production. There is just an increase in the epinephrine. That too an attenuated. What is attenuation? That means a small amount, like if a production of 50% of epinephrine is required for normal non-diabetics to produce a response of to epinephrine, the same response will be produced in the diabetics just with a 20% increase in the epinephrine. So a small amount is enough to produce an increase in the to produce the symptoms of increased epinephrine production. I hope you understand. Okay, so another thing in diabetics we see is hypoglycemic associated autonomic failure. This is just a mechanism, it will make us see how deteriorating hypoglycemia is on the patients. It's just a like concept, that's it. So it is seen in insulin deficient patients. What is that is that recent antecedent iatrogenic hypoglycemia causes defective glucose counter regulation and hypoglycemic unawareness. So this word is very important, hypoglycemic awareness. I'll explain. Causing a vicious cycle of recurrent hypoglycemia. It's not that it's not a important question for you or anything. It's just a concept that you it will be interesting, that's it. So in the early type 2 diabetics, there is marked absolute therapeutic hyperinsulinemia. I have already said it. So there will be falling glucose levels, and there will be isolated episodes of hypoglycemia because of the increased hyperinsulinemia. So that is fine in the early stages. Whereas in advanced type 2 diabetes and type 1, where there is absolute beta cell failure, there will be mild to moderate hyperinsulinemia. That's it, because the insulin production itself is very low, and there is falling glucose levels. So okay. And then there is a beta cell failure, right? When there is beta cell failure, there is no decrease in insulin or no increase of glucagon. There is just an increased epinephrine. That's it. That means you get symptoms of hyperglycemia. So these hyperglycemia, we have episodes of hyperglycemia. What this does is the attenuated sympathoadrenal response to hyperglycemia. That means so the sympathoadrenal outflow, the epinephrine, norepinephrine, acetylcholine. So these are the sympathoadrenal outflow. Okay, these are the hormones that cause the symptoms of hypoglycemia. So what they do is there is attenuated sympathoadrenal. That means there will be decreased response. Okay, and there is decreased adrenomedullary epinephrine responses and decreased sympathetic neural responses. So these decreased responses, they cause defective glucose counter regulation, and this decreased sympathetic neural responses causes hypoglycemic unawareness, and they in turn causes recurrent hypoglycemia. So what the concept is that the diabetic patients will have an episode of hypoglycemia. Then after that, there will be decreased response. That means first the patient, when he has 70 milligrams of deciliters, the patient will have symptoms of hypoglycemia, but the body becomes attenuated. That means it will stop responding to the sympathetic system. So after that, the patient will have 60. When the patient has 60 only, then he has the symptoms of hyperglycemia. Antavaraku raadu. After that, slowly it keeps on decreasing the value. Later it becomes 55, later 50. later 40. Until 40, until the glucose levels goes 40, only then they will have symptoms of hyperglycemia, because that is very dangerous. As we have already seen, when the hyperglycemia, when the glucose levels falls below 50, they go into the cognition will be decreased and the patient will go into coma, unconsciousness and coma. So the patient, they will bypass all these symptoms, the symptoms of sweating, tremors, palpitations, all will be bypassed, and the patient will go straight into coma. That's why it's very important to prevent recurrent hypoglycemias. Even one episode of hyperglycemia will predispose the patient to the autonomic failure. That means the body stops responding to the hypoglycemia. It will not produce the sympathetic outflow. That it just becomes non-responsive. That's it, which causes in turn hypoglycemic episodes. So the glycemic threshold for symptomadrenal response is shifted to lower plasma glucose concentrations. That shift is typically the result of recent antecedent iatrogenic hypoglycemia. So what is hypoglycemic unawareness? Is loss of warning, adrenergic and cholinergic symptoms that previously helped to recognize hypoglycemia. Okay. So what are the causes? Coming to the causes, we'll see it as physiological and pathological. Physiological causes are late after a meal, like 4 to 5 hours. Pregnancy is another physiological state where there will be recurrent hypoglycemic attacks, or else when we have prolonged fasting. This is causes of in ill patient, any ill or medicated patient. Drugs can cause, like insulin, obviously, alcohol. In critical illness, any failure can cause hypoglycemia, hepatic, renal, or cardiac. Because hepatic and renal, they are the sites of gluconeogenesis. Sepsis can cause a state of hypoglycemia. Hormone deficiency, like cortisol deficiency, glucagon deficiency, epinephrine. These all are caused in um, like they increase the production of glucose, right? So these deficiencies causes hypoglycemia. Non-islet cell tumor. So these are in ill patients. What should we do when what are the causes when the patient is normal, like he seems well, he appears healthy. So when those people have hyperglycemia, the causes we should see are endogenous hyperinsulinism. So this is the cause of exogenous hyperinsulinism. That means we give it from outside, so they are having uh, increased insulin. Whereas the increased production of insulin in the body, what are the causes? Insulinoma, tumor of the insulin islet cells. So functional beta cell disorders like non-insulinoma pancreatigenous hypoglycemia, post-gastric bypass hypoglycemia, which we do for um, obesity. Autoimmune, insulin autoimmune hypoglycemia. When there is antibodies to insulin and insulin receptors, they destroy these cells and causes increased insulin. When there is a ingestion of insulin secretagogue, like glimepiride, etc., and or else accidental, superstitious, or malicious hypoglycemia. So drugs are in diabetics. There is exogenous insulin and insulin secretagogue. That means they stimulate the beta cells to secrete the insulin. So we use them in diabetes. Those are glimepiride, glibenclamide, glipizide, repaglinide, and nataglinide. Alcohol it inhibits the gluconeogenesis. Therefore, we should suspect hypoglycemia in alcoholic patients, chronic alcoholics. Others like AC inhibitors, ARBs, beta blockers, quinolone, etc. Sepsis, these are the in sepsis there is cytokine accelerator. Cytokines cause the increased glucose and glucose utilization. That's why it causes hypoglycemia. CKD, chronic kidney disease, impaired gluconeogenesis, and severe liver failure. Gluconeogenesis and glycogenolysis are impaired. Cardiac failure, we don't know the mechanism. The hepatic congestion. In right heart failure, we see hepatic congestion, right? Hepatomegaly. So that may be the cause. And any Addison's disease, like in adrenal insufficiency that can cause hypoglycemia and hypopituitarism. Another cause of hypoglycemia, non-islet cell tumor hypoglycemia. Um, Normally, in islet cells tumor, we see like insulinoma and we see hypoglycemia because there is increased production of insulin. What is non-islet cell tumor means? Um, the tumor is somewhere else in the body, like we see it in large tumors of mesenchymal epithelial cell. So it is as a result of production of incompletely processed insulin like growth factor 2, IGF-2. So IGF-2 to IGF-1 ratios are high during hypoglycemia and free IGF-2 levels are elevated. Therapy is with steroids. So we have already seen the cause of endogenous hyperinsulinism, like in an overtly well individual with no clues, clinical clues to common cause of hypoglycemia. So any ingestion of beta cell secretagogue, like that, not in even in normal individuals, these cause the hypoglycemia, insulinoma, nisidioblastosis, insulin autoimmune hypoglycemia, post gastric bypass. There will be failure of insulin secretion to fall to very low levels during hypoglycemia. Insulin, C-peptide, proinsulin levels measures are inappropriately high in setting of low plasma glucose. A low plasma, normally in low plasma glucose, what we see is the insulin production will be decreased, right? So insulin should be decreased when there is decreased glucose, but they're like inappropriately increased. The insulin levels are increased when the insulin degrades to C-peptide. So it produces C-peptide that will be increased. Proinsulin, when the proinsulin gets converted into insulin, all these are increased in hypoglycemia. Normally they should be decreased. Okay. Um, so these are the values like when the plasma glucose concentration is less than 55, the plasma insulin will be increased, C-peptide will be increased, proinsulin, beta hydroxybutyrate, all these will be increased. Beta hydroxybutyrate will be decreased. Sorry. When these appear, we have to think it of as endogenous hyperinsulinemia. So a low plasma beta hydroxybutyrate concentration and an increment in plasma glucose greater than 25 after IV administration of glucagon is increased insulin action. So what is insulinoma? Is an insulin secreting pancreatic islet beta cell tumor. Very uncommon, 90% are benign, and they are commonly seen in older age, like 50 years, and they are seen in men's. They're diagnosed by ultrasound, CT, MRI, somatostatin receptor scintigraphy. So scintigraphy scans can be useful, and we can diagnose it with intrapancreatic ultrasound. So like in the OT, they will just use a pancreatic ultrasound and diagnose the tumor. Treatment is by surgical resection. A drug we can use for this condition is diazoxide. It is a potassium channel opener. Okay. So when the potassium channel is opened, there will be depolarization, sorry, hyperpolarization of the beta cells and causes decreased production of insulin. So diazoxide, just remember it. And octreotide can be used. Even everolimus is an immunomodulator. Other medications are verapamil, that is a calcium channel blocker, alpha glucosidase inhibitors, and glucocorticoid therapy. Accidental superficious or malicious hypoglycemia, that is accidental ingestion or administration of insulin or insulin secretagogue. All the features are similar to insulinoma, except in the ingestion of insulin secretagogue, there will be increased C-peptide levels, just as in insulinoma. Okay, because the normal, it increases the production of insulin. Okay, through genuine mechanisms, like through there will be beta cell depolarization, which causes increased insulin. But in the exogenous insulin, there will be low C-peptide levels because the degradation of insulin is different from normal endogenous insulin and exogenous insulin. So that's the differentiating factor between insulin secretagogue and insulin. Okay. Um, So we diagnose this, we measure plasma glucose, insulin, C-peptide, proinsulin, and we'll see afterwards. A 72-hour fast test can be done. Okay, yeah. This is a 72-hour fast test where the patient is made to fast for 72 hours, and we measure the levels like every fourth hourly and or sixth hourly of the insulin, etc. So if it is exogenous insulin, there will be increased insulin levels in the body. That is obviously even in insulinoma and in sulfonylurea, because all these are causes of and insulin production, increased insulin states. So what's the differentiating factor? We have already seen that the sulfonylurea and insulinoma are very similar. So both will have C-peptide, increased C-peptide levels. So if there is decreased C-peptide levels, then we can diagnose it as exogenous insulin. So it's ruled out. And there will be decreased pro-insulin levels also. So whereas it is opposite in insulinoma and sulfonylurea. But how do we differentiate between insulinoma and sulfonylurea means? We have to measure the levels of sulfonylurea in plasma or urine. I mean, we have to keep it in mind, and we have to once take a sample if the patient is having recurrent hypoglycemia. So this is the workup. First we see for C-peptide levels. If it is if the C-peptide levels are low for insulin, then the insulin is given from outside. Whereas they are equal to that of like the C-peptide levels are increased, it can be factitious sulfonylureas. That means the sulfonylureas are given from outside, or it can be autoimmune, or it can be insulinoma. So there will be three causes. How do we rule out? As we have seen in the previous slide, urinary or plasma sulfonylureas can be measured, and if there are high, then we can diagnose it as oral hypoglycemic injection. But if there is absent, then we are left with two causes, autoimmune and insulinoma. And then we measure the pro-insulin levels. Okay, these pro-insulin levels, if they are around 10%, then it is the cause of autoimmune. But if the pro-insulin levels are very high, like greater than 20%, then we can diagnose it as insulinoma. Yeah. So coming to the treatment. So obviously for the treatment of hyperglycemia, we should give insulin from outside. How do we give it? The route and amount of administration will depend on the glucose level and as well as the patient level of consciousness and available access. Okay. So what does the patient level of consciousness come into? If the patient is conscious, we can ask the patient to eat, simply eat the food. Okay. Whereas the patient is unconscious, the patient will not be able to eat, right? So then we give it through IV. Where possible, an oral carbohydrate load should be administered urgently, followed by careful blood glucose monitoring. So the rule of 15, that is 15 grams of carbohydrate will raise the glucose level about 15 milligram deciliter in about 15 minutes. So if oral route is not possible, as in unconscious patients, IV glucose, intramuscular or subcutaneous glucagon. So exogenous glucagon we can give glucagon injections. This dose of glucose will typically maintain euglycemia for up to 2 hours, and then we can ask the patient to eat. So this is just a simple flow chart. Like if the glucose is less than 70, if the patient is unresponsive or severe, or when there is neurological dysfunction, we give the IV dextrose. We don't have D50, we just have 25D in our emergencies, like in our hospitals commonly. We don't typically use 50D. 25D is normally used, so that 25D is 100 ml. We just keep a bottle of 100 ml of 25D and administer it immediately. Or if it is not available, glucagon 1 mg IM or subcutaneous. Or else we can give it via feeding tube. That is another option. Like we combine it with normal water and give it through a feeding tube. If the patient is able to eat, then or a patient able to take oral medications, then we can give glucose tablets. We ask the type 1 diabetics to carry some glucose tablets. So whenever they feel that they are going into hypoglycemia, they just ingest it. Or else any milk or fruit juice, anything is sufficient. We have to keep repeating the glucose readings at 10 to 50 minutes. And if they are okay, like if they go above 70, then we can give, ask the patient to eat, or we can, if the patient is still unconscious, we can uh, start a lower level like 5D. We use 5D, or even DNS can be used, normal saline with dextrose, so that we can hook up to the patient. And if the patient is having recurrent hypoglycemia, then we can give octreotide 50 micrograms 6 to 8 hourly. IV dextrose infusion should ensure delivery 6 to 9 mg per kg per minute of glucose. That's the normal value. So we just give oral is the best route, and complex carbohydrates we have to include a meal of complex carbohydrates if the patient is able to eat after maintaining the glucose, after we make the glucose above 70. So what are the complications? Recurrent or persistent psychosocial morbidity like emotional liability, irritability, depression, like the fear of hypoglycemia. So the patient will be afraid to take insulin injections because of the fear of hypoglycemia, seizures, permanent neurological deficit if it is recurrent, coma, and death. So these are the complications. Thank you. So any doubts?